All right, thanks so much. I'm very honored to be here with you today. And hopefully what I'm going to do today will allow for some consolidation of knowledge from the two previous speakers and put it into a context that may or may not represent you in this room, but hopefully helps you think about what we're thinking about when we're meeting with you, but also how we're trying to read your mind as to what you're thinking too. So hopefully this opens channels of discussion between you and your practitioner when it comes to your care. So these are my disclosures. I do have research funding. I do get funding for speaking at different meetings, but I also lead clinical trials that are investigator-initiated through the Canadian Cancer Clinical Trials Group, but also through industry partnerships. So hopefully by the end of this talk, oh, and the time has not started yet. So someone please start the time. I was very thankful because I'm like, oh, I forgot my phone, but there's a big 45 minutes up here. Understand the role and impact of molecular testing in treatment decisions and how that applies to you, but also understanding that our context might be a little bit different than our American colleagues' context so that you can understand what that perspective is. And as Alina highlighted, trying to understand where continuous versus time-limited therapies are used and why. And then let's talk a little bit about how this impacts you when it comes to the accessibility and tolerability of the treatments. So my approach to CLL patients for the first is do no harm. We're talking about an incurable cancer, especially in patients over the age of 65, where the goals of care are really focused on quality of life. And as you've heard, because there's no evidence for early intervention, active observation is really the key in patients who do not meet criteria for treatment. And so you can see here that I had this slide almost 10 years ago, and I used to put chemotherapy as the word, but the reality is we've shifted away from that and we're looking at treatments instead. And there's multiple different types of treatments, as Alina highlighted. And, you know, at the time that I used to give this talk, we used to talk about the only curable option for patients were really those that had very aggressive disease and that required a bone marrow transplant. And the reality is, in the last 10 years, I think I've only sent 2 patients that route because we've had so many new innovative treatments that have helped to impact the well-being of our patients. So you've seen a lot of graphs today in these talks, and we've talked about things like progression-free survival and overall survival. But what I thought I could do is just map one of the journeys that a patient could have. And I'm not sure. Oh. Okay, so basically what I have here is your tumor load on what we call the y-axis, which is the vertical, and kind of time on the x-axis, which is the horizontal. But what you see there is that burgundy box where some of the complications or concerns associated with the disease may present before your diagnosis, and that is infections or potentially even other cancers. And then you get your diagnosis. And then you have on the top here that little TX, which is the treatment. Now the time that goes from the time of diagnosis to the time of treatment is that active observation period, or the time to first treatment. And then people go into a remission, which can be deep if it's a CR, which is a complete remission, a partial remission, or a nodal remission. And so those are different terminologies you will see in papers or clinical trials, or a lot of the language that you'll hear some of the physicians speak with you when you're in your appointment. But really what we're looking at, how long can we keep you in that remission before you need treatment again? So that would be your progression-free survival. Now with the new treatments we have now, that could be a remission on treatment or a remission off treatment. Because the reality of the situation is when we first developed this graph, treatments were 6 months and they were done. But that's no longer the case because we have patients receiving continuous treatments or time-limited treatments. And then when you start to relapse or progress is when you would have your time to next treatment. But during this period of time, that immune suppression is still an important thing to think about. And some of that is related to your cancer progressing because now you're out of remission, and or the treatments itself because of the immunosuppression that those treatments have. But one of the things that we're always interested in is how that immunosuppression affects survivorship. And that might be one of the key features when we think about prevention when it comes to infections or other cancers. So I would credit Dr. James Johnston for developing this slide, and I think it's in one of the textbooks in the chapters that I learned way back 20 years ago. So let's start with a case. So this is an 89-year-old, and I didn't put a male or female here, but with a new diagnosis of CLL. They have an abnormal white blood cell count, and the lymphocyte is 10, the normal range being 1 to 3. The hemoglobin and platelets are normal, and they have no symptoms. So what do we do in this case? So I think one of the challenges that we face in the cancer community is that cancer is always portrayed as a battle, something we have to win, something we have to conquer, something we have to cure. But the reality of the situation is when you're a patient that has chronic lymphocytic leukemia or small lymphocytic lymphoma, you're actually someone with a chronic cancer or a chronic disease. And so your mentality and our approach as physicians in this case really also has to change, because we really don't want to do any harm. We want to ensure that we're monitoring you through your survivorship, and that could be even without treatment. So typically what is done in the clinical practice is that that patient who requires no intervention at this time still requires that active observation to make sure they don't get to a point that is too dangerous and that happens too late, and therefore we're trying to catch the patient and get them well while we could intervene at maybe just the right point. So we know that they're heading there, but they haven't actually become unwell. So this is done by routine blood count monitoring. We usually look at the blood chemistry levels, your kidney function, liver functions, but there's also certain blood parameters that we're looking at on those tests. So these are simple tools that can be done in any doctor's office, the beta-2 microglobulin, and then that's a marker of disease burden in our patients. We do measure your immune function through tests called immunoglobulins, and this helps us to understand if your immune system may be compromised because it can't make the antibodies to fight off infections. So this is something, depending on your practitioner and the clinical practice you're in, that could be done at least on an annual basis to monitor. And in those patients that may have more infections, that is something that could be done more often. The frequency of the follow-up really depends on your stage and your clinical picture. So some patients may be seen every 2 years by their hematologist, some every year, some every 6 months, some every 3 months. But that really depends on the numbers that we're monitoring. So those are things that we are kind of designing on a personalized basis. Now, there's some other factors from the patient perspective may also drive that. Someone's not comfortable being seen every 6 months, and they would like their blood test done every 3 months. Now, that's a conversation you need to have, because part of what we do is also manage patients' mental health and well-being through this process. And sometimes it's that reassurance that allows for them to be comfortable and accept this diagnosis and start to live with their diagnosis. So the prevention piece is something that this patient would also have, which would be immunizations. We talked about the flu, the COVID, the pneumonia, the non-live shingles vaccine. Sometimes we may also advise hepatitis, or at least hepatitis screening for antibodies, mainly because in the future when patients require treatments, some of the drugs we use may reactivate hidden hepatitis. So depending on where you come from the world, and we have huge immigration changes in the Canadian environment, so some people might carry a hepatitis that is unknown. So it's really important to know and understand that. Lastly, we talked about, I have the word poop on slide, I realize that now. But the last thing we talked about is the risk of second cancers. So one of the things that's really important here is when we think of the immune system, we always think of it when we are fighting infections. But all of those different immune cells have a communication network. And the CLL cells have basically disrupted that communication network. And as a result, that is what makes the patient more susceptible to those infections, but also to second cancers. We now realize how important the immune system is in removing abnormal cells from solid tissues, so lung, bowel, breasts. Some of these solid tumors that are very common in the general population happen about twice the rate in patients with CLL and SLL. Skin cancers happen at a 4 times rate. And so these are things that we need to think about and understand. And the more we can do to educate you around those risks, the more protection you have, and that you're aware and can bring it up to your provider if you notice something, specifically blood in your stool or a mole that's changing. Those are important things to bring back to your provider. So as we discussed previously, the primary goals of treatment is to improve the patient's outcomes, their overall survival, but it's also to control their symptoms and improve their quality of life. And we can only do this if we provide patients with tolerable treatments. So the next cases are really going to focus on sort of why we're doing what we're doing. So one of the things we didn't really touch about is that although we're trying to make people feel well, the other things we're trying to do is maybe change some of the existing biology that is created by the cancer itself. So if we control your cancer, then maybe we prevent those additional mutations from forming in the cancer so they're not as aggressive in the future. Maybe by getting rid of these abnormal cells that are poor communicators, we can reset the immune system and your body can respond better to immunizations. You can fight things off better. And finally, if we eradicate these abnormal cells, we reinstate that communication system that allows for your body to naturally get rid of abnormal cells in other solid organs. So we talked about the indications to treat, and so I'll just review those again. Increased lymphocytes, uncomfortable large lymph nodes, symptoms that we talked about, fatigue, night sweats, weight loss, and then the immune problems. Important to know that that high blood cell count in itself is really not an indication to treat. We have patients in our clinic, we follow about 1,500 patients between 2 physicians, and some of those blood counts range from like the normal range to 500, 600 when it comes to the white cell count. As long as the hemoglobin and platelets and the bone marrow function is well preserved and you feel well, that is an important thing to take away from here. So it's not as how high that blood count gets, but it's the rate at which it changes and the impact it has on you as an individual or those other blood counts. And so the one thing I wanted to bring in is the timing of molecular testing. So when we look at the literature, molecular testing is done at diagnosis. But unfortunately in Canada, it is an expensive test. And at diagnosis, it doesn't really inform anything other than routine follow-up. Now, in other jurisdictions, like in some of the Nordic countries, they're using early molecular testing to say, oh, maybe you can have a different type of follow-up, be in a survivor clinic because you have low-risk disease. And those that with more intermediate and high-risk disease are those followed by hematologist or a CLL clinic. So there are some ways it's being used, mainly to manage resources that are finite when it comes to medical care. But in Canada, otherwise, the way it's being used is to determine what treatment one should get. So I have that molecular testing right over that treatment box to say this is typically in Canada when you would expect to get that molecular testing. So the questions I'm often asked about is, what do I think about when I'm having that discussion with a patient in terms of what treatment they should receive? So on the left is what goes through my brain when I'm trying to understand how to treat the patient. So the first box is, what is their molecular testing status? The second box is, with that information, what first-line therapy would they be eligible for? But then I'm not just thinking about now, I'm also thinking about the next line of therapy. So there's a huge mental exercise that goes into thinking for this individual at this age, with their other medical conditions and the molecular profile of their cancer, what is the right treatment that they require? And so this is really, if we have decided that chemotherapy is something of the past, what you see on the right is sort of the standard guidelines on how to approach a patient today with chronic lymphocytic leukemia or small lymphocytic lymphoma. It really depends what you get in the front line as to what you're going to get in the next line, and that in consideration with some of the molecular profile features that we talked about. So this is a case of a 50-year-old gentleman who is diagnosed with CLL in 2015. He had low-stage disease at the time. He had no negative prognostic markers and had no medical issues, drives, and has full-time employment with benefits. And at the time that I saw him, he was in active observation. He was routinely follow-up every 6 months until 2018, and then the examination started to change. He had progressive lymph nodes, 2 to 3 centimeters, and I could start to feel his spleen below his rib cage. And he started to have progressive symptoms. He's saying that he was having these sweats. He would wake up in the middle of the night, but his sheets weren't wet. And this was happening initially once every so many weeks, then once, and then a couple of weeks, and then it started to increase in frequency over time. The other thing, he's like, I work full time, but I'm getting more tired, but maybe it's just because I'm, so many years older than I was. And I, have a really different approach, I think, to when it comes to the symptoms of a patient. Because a lot of times, it's really hard to gauge whether the CLL is the only thing responsible for those symptoms. So, this is very small, I apologize for that. Assessing the symptoms is a really important part of our conversations with our patients. And it's important for us to understand that these symptoms are affecting your quality of life. But we're often not trying to minimize the impact of those symptoms, but trying to understand if our intervention is going to improve your symptoms. So that means that we have to be detectives, and we have to try and understand what the cause of those symptoms are. So sweats can be multifactorial. They can come from other medical problems like thyroid disease. Sometimes people's heating, cooling systems in their homes are impacting their ability to sleep at night. There's hormonal changes that occur as people are transitioning through different phases of their lives. And the main thing is, are these sweats bad enough that they're impacting your quality of life? So those are important things that we want to hear and understand from you. So don't be afraid to bring these up and talk about your symptoms, because they're an important part, and I'll show you why in this case. So the other thing that people ask about is fatigue and decreased energy. And that's a really hard symptom to kind of figure out what the cause is, because as we have patients that span different age generations, there might be different causes of tiredness. So I always probe and ask, how busy are you? Are you working 5 days a week, and then are you entertaining your family? Are you visiting on the weekends, and then you're tired because you're doing all that? Or are you starting to notice that you can't do those things? Has your ability to do the things that you love dropped? Are you slowing down? And that comes with other questions that have to be answered as well. Do you sleep well? Sleep is often dysregulated as we age, and there's different causes for that sleep dysregulation. Some people have undiagnosed medical problems. Some people have hormonal changes that may impact those things. So those are things we're trying to probe and trying to understand. And the other thing that I think is really important is that we get to journey with our patients through certain phases of their lives, from when they're busy working to retired, to kind of enjoying things in life. But with that also comes significant life changes, life losses that may also affect the mental health of the patients. And as a result, we should be probing and understanding your situation to understand, is this fatigue related to changes in your mental health? Is there a chance there's some depression? And we're not saying that because we don't believe your symptoms, but we want to make sure whatever intervention we're going to take is going to actually improve your symptoms. Because it would be terrible that if I attributed these symptoms to your cancer, treated your cancer, and they didn't get better because it was caused by something else. And I think that's an important thing that we want you to understand, and why it's really important that you're forthcoming with some of these things that are hard to share, but really important to share. And so, again, is the fatigue impacting your quality of life? And so these are the main reasons around that, which is any intervention we take, the goal is to improve your quality of life. And we don't want to make you sicker with the treatments and put you at risk. We've come a long way. We have really great treatments, but they're not without risk. And so we want to ensure that if you have no other causes, like your lymph nodes are not large, your spleen is not big, and your blood counts are actually normal, and all you have is a high white count, we want to make sure that these symptoms are related to the cancer. So we used to use a simple tool because we needed to make sure that you could tolerate drugs like chemotherapy, and the organs you have in your body could process those drugs so that you wouldn't get side effects. So we used to use age, fitness, which was based on all the medical problems that you might have, and those organ functions as the way to decide if you should get 3 treatments together in chemotherapy, 2 treatments together, or 1 treatment together. So it was a combination that we used to use. But what I wanted to show here was the more effective the treatment, the higher the risk of side effects. So when we're thinking about a patient that doesn't have any measurable things that we can purely say that your hemoglobin got better, your platelets got better, your white count came down, it makes it really hard to put you at harm's way when we don't know it's going to benefit. So that's why those conversations are really important. So this young fit man received FCR at that time, and he did not have any molecular testing at the time. So I did want to touch about one thing, because what I hear a lot about is the chance of cure with FCR. So there's just a few slides with curves, but they're just trying to show you in a cohort, there's some historical data that allowed for improvement in patients who were treated with chemotherapy. And so the red curve is the overall survival, the orange curve is the progression-free survival in patients who were treated with fludarabine, cyclophosphamide, and rituximab. But how they did as an entire cohort depended on their molecular profile. So this is just to show you, if you had mutated disease in panel B, you were the red line. If you had unmutated disease, you were the green line. So not everybody does the same with all treatments. And that was one of the key findings in some of the studies that Alina presented, that chemotherapy lost to some of the novel agents. And that's because the novel agents eliminate that difference. But I think what was really impressive is that there's that black solid line that's crossing the red line. So that black solid line that's crossing the red line is the survival of individuals without cancer. And if you take the mutated population, which is that low-risk population, those lines are almost superimposing. And the reason they're superimposing is that there's a small subgroup of patients, when treated with that chemotherapy regimen, if we achieved a very deep response, meaning we could not detect any measurable residual disease or MRD negative, they have what that flat line is, which is essentially considered a cure. But this comes at a significant cost. And what we've learned over time is that although this regimen has been along for a long period of time, many people have not used it as much as they used to because some of the side effects and the long-term follow-up studies. So in this cohort of patients, 96 patients developed 106 other cancers. And you can see the types of cancers. They could have been solid tumors, melanoma, but one of the things that we're most worried about is another more aggressive leukemia or bone marrow failure syndrome, such as myelodysplastic syndrome. I think it's really important to know that this comes at a price, and we are only looking for a very small group of people that might benefit. And so now studies are going head to head with this treatment and showing some of these novel agents might actually be better than this treatment. So unfortunately, in this kind of fictional case, one of the risks that can happen with such a treatment like FCR is bone marrow failure. And so patients might need other types of treatment to help their bone marrows in the future. So this patient relapses, and sorry, I'm going to transition. This has nothing to do with the patient. This is to recap some of the key things that you've heard around risk stratification. So one of the things that I explain to my patients is every individual sitting in front of me has a different story, both based on their medical background, but also the cancer themselves. So the cancer cells themselves can be classified into a risk category. The high risk, like the P53 mutations, the intermediate risk, like the unmutated 11q, trisomy 12, normal FISH studies, and the low risk, which are the mutated patients or the 13q deleted patients. Now, important to note, a lot of this risk stratification was based specifically when patients received chemotherapy. We still have some signal that the highest risk patients may still have shorter responses, even with the new treatments we have available. But this is kind of, I would say, the best way that I can inform you on what your risk is when we meet when it comes to choosing treatments. So this is a young, fit patient with IGVH mutated disease. He has no P53 or high-risk abnormalities. And I ask this question to you as the audience. I know that we don't have a digital polling, but if you're comfortable raising your hand, I'm going to go through the choices, and I would like to know, as a patient, after hearing some of the treatments, and I know you don't have all the information, do you have a treatment selection that you would be most interested in receiving? So if these were all funded, if you could raise your hand, how many of you would pick FCR as your first line of therapy? How many of you would pick venetoclax in combination with obinutuzumab as your first line of therapy? Okay, so about 10% of the room. Ibrutinib and venetoclax as your first line of therapy. That would be the BTK in combination with the BCL2 inhibitor. Okay. And then acalabrutinib plus venetoclax, which would be a second generation BTK inhibitor plus venetoclax. So similar to Ven-O, but more than IV. How many people would go on to a continuous treatment with a BTK inhibitor? Easy, pill, one and done. All right, so probably the same amount as IV. Okay, so in this case, Ven-O wins out. So there's lots of things that go into the decision-making around this. And I think you have already seen sort of how these drugs work. But the best thing is that we have lots of different options to shut down that growth pathway of the CLL cells that promote survival. But it does come at a cost. And so I will warn you, there are some images of patients that have given me permission to share some of the things, rashes, things like that, that they may have had. So if you're not comfortable with that, close your eyes, and then I'll tell you when I'm done with the next slide. So some of the side effects, as Alina mentioned, of the BTK inhibitors can be bleeding and bruising, but can also cause serious heart rhythms, abnormalities. And so this is a patient that had not just atrial fibrillation, but an abnormality with the lower chambers of the heart having an irregular heart rhythm. You can get deep infections of the skin, and you can get changes in your nails. And so when we moved from the first generation to the second generation, this allowed us to really not think about a lot of these side effects, but the main things that we worry about are high blood pressure, still the irregular atrial fibrillation, but the rest of those infection and the rest of those side effects were a lot less compared to that second generation. When it comes to the venetoclax, it's a drug that reactivates the cell death pathway, and that death mechanism is called apoptosis. So if you hear about cell death mechanisms, it's a way to wake the cells up so that they have that timed life cycle again, because they should only last in your system about 7 days to a month. And then we heard about the changes in the mineral balances. And the reason I'm bringing these things up is when we're thinking of the treatments for the patients, we need to know how is this going to affect you in your life? Because these types of side effects require that constant monitoring. You need to come to a center, have a blood test. You might need to be admitted depending on how severe those changes might be. You need to be available so that you come back if you need to get intravenous fluids. And that doesn't apply to everybody, but for those select few in whom it happens, it can be quite a change in the quality of life that they had prior to treatment. And so you already heard about the challenges that we had with the ramp up, but I just wanted to say that it does factor into the decision making in who's coming next. And what's coming next for the treatments, because that person that enters through the doorway doesn't just have the cancer as the problem. I want to make sure that we're addressing the accessibility issues, how they're going to come to the appointments, how they're going to tolerate a lot of the interventions, and are they fit enough to do that. So we're really trying to improve outcomes, but it comes with the balance of costs, of the cost of the side effects as one of the main key features. I'm just going to put up the Canadian funding algorithm. Both we have some American patients and some speakers from outside to show you sort of what is available in Canada. And I know that these are provincially dependent, but for the most part, many of us practice this way. So if you don't have any high-risk features, you still have chemoimmunotherapy, then you have venetoclax obinutuzumab, ibrutinib, venetoclax, and acalaven is currently being reviewed. If you have, that would be your frontline treatment. And based on what you get in the frontline, this is what is available in the second line treatment. So a lot of the drugs that you have heard about already today. So the main thing is that this is available publicly on the CDA, the Canadian Drug Agency site. And you're able to collect a lot of the information. There's a patient perspective and what's valuable to patients. You can also contribute by working with the organizations to advocate for some of the new treatments. In the relapse setting, this is, you can see chemoimmunotherapy has kind of been lost, and you have the high-risk features the high-risk features have predicted loss of chemoimmunotherapy on the algorithm. And some of the same treatments are available, but it really depends what you got in the front line as to what you're going to get in the second line. So this is the second case. Things to think about. This is a lady who's 71 years of age. She is of a Black origin. She has severe high blood pressure on 2 medications and end-stage kidney disease with low kidney function. She requires treatment. She is IGVH unmutated. She does not have any P53 abnormalities. And my question is, how would you treat? So you can see here that instead of FCR, I've replaced the chemoimmunotherapy option with what was approved in older, unfit patients, which was chlorambucil obinutuzumab. And then you really have the same treatment options that we kind of talked about in the frontline setting. Now, one of the challenges we have is it's not really about picking the right answer here. It's about picking the treatment that best suits this individual. And part of that is, how can we support you through this journey? How do you come to your appointments? Which treatments appeal to you and why, thinking about the side effect profiles, your other medical conditions, and what are the things that influence your selection. And I think it's really important for us to hear that perspective. Now, often I will also get, but doctor, I would like to hear what you would like me to get. And I think that that's a conversation that I can only have based on the efficacy, your medical treatments. But there's some things that might sway the decision based on my son drives me to all my appointments. He works on certain days. I'm not independent to be able to come in that way. Are there resources that can be added to help me, achieve the best treatment for me in my condition? Or is this treatment just as good? And I think it's important to understand that although we don't have head-to-head studies, all the treatments we have available right now are excellent. And every person in front of us has a different story, so that selection and that conversation is so important in helping us to choose. And that brings us to something I think the patients can do the best, which is help us to advocate for equity in medicine and treatment of our patients. How do we make the treatments more tolerable? Someone talked about dose. We study maximal tolerated dose, not maximal effective dose. How do we remove the ageist lens from the care of our patients? Because one of the things that often is said or referred is that, should I be sending this person to you? They're 89, they're still independent, but would you offer them treatment? So there is a little bit of a lack of knowledge around the fact that elderly patients live well. And even if they're an older individual, they are still independent and they should have the same options and at least the consultations to make the decisions on their own. So part of this comes with shared decision-making and understanding that we're in a partnership with you as the patients. And we don't want to be seen as someone that will be offended by a comment. We don't want to be seen as someone who would be obstructive to a collaboration. We really want to build a relationship with you, but also with the communities that we serve, whether they're medical, scientific, or patient partners. And these are important pieces that I think there has been a moment in medicine and time where the approaches may not have been as I've described, but I think there's a significant shift because patients are also more knowledgeable. The access to information is big. So I think the reality of the situation is, the more we can do together, the better it will be for everybody in the end. And so, like I said, don't rule out therapy without talking to your friendly neighborhood hematologist or oncologist. And so in this patient, I removed the chemoimmunotherapy as an option because they're IGVH unmutated, but reality, there's no right answer to any of the choices here because the reality is the Acala, the ibrutinib, and the Xanu would be very tolerable, but we have to manage some of those high blood pressure effects. The venetoclax obinutuzumab, because of the kidney function, we might need to think about how we do this. Now, there's a recipe that we're provided from the clinical trial, but not everyone follows the recipe. that's the reality of life. You're going to make tweaks, you're going to adjust things so that the patient may be able to go through the treatment in the best way possible. So those are something that, depending on how poor the kidney function is, may not be safe. Or if it's reasonable, we might be able to just tweak the recipe a little bit so they're able to get that treatment. So like I said, there's no wrong answer. It's just a lot of doors that are open and picking the door for you to walk in that is best suited to you. These are the high-risk options, so you can see that there's no chemoimmunotherapy listed. And it doesn't matter to me if someone is 50 or 80, but it's going to be the medical conditions that they have associated with their well-being that's going to impact my decision, because I don't want to add more side effects to conditions that they already have. So if you have really difficult to treat high blood pressure, I may not pick one of the BTK inhibitors that has a high risk of high blood pressure. If you already have atrial fibrillation, then I'm not worried you're going to get atrial fibrillation. So I could pick any of those. So there's lots of different options, and like I said, it's really who is in front of you and what medical conditions they have and what the goals of care of the patient are as well. So one of the things we didn't talk about was the length of treatment. The length of treatment is important because if someone's in a treat to progression treatment regimen, then they might develop some of these side effects slowly over time. So we really need to ask, what is your goal? Would you like to be in a remission and done? Or do you want a treatment-free period? And I think it's important for us to understand those perspectives, because even if you're in the highest risk category, it doesn't mean that you can't have a time-limited treatment if that's part of your goals. So I think it's important for us to explore those things as well. I'm going to skip this because I think I'm saying the same thing over and over again now, which is really it's a partnership and shared decision-making that leads to this. So I think in Canada right now there's a few debates that are occurring. One is, does high-risk treatment require continuous treatment? Or can we also use time-limited treatment in these patients? But there's lots of factors that go into the decision-making process, which are the medical reasons, but also the patient factors, the choice, the coverage, the accessibility, and the system factors. How easily can we get you into a center for treatment? How quickly do you need the treatment? Those are also things that we are thinking about at the same time. So just to end the talk, I did want to show some data from Manitoba just to show what the impact of novel agents on the survival of patients was. So the dark blue line was the survival of our patients when we didn't have access to novel targeted agents. So the lower the line, the worse it is. And the green line is when basically ibrutinib came into clinical practice and how we were able to salvage patients that had relapsed post-chemotherapy and the improvement that the novel era of agents has had. But this does come at a cost. We're in the public healthcare system, and I think it's important for every patient to understand and every practitioner to understand that when we are extremely grateful for the privilege we have in allowing, in accessing these treatments for our patients, but the cumulative costs for the novel agents, if you're getting them on a continuous basis, it's about $100,000 a year. And on average, the patients are on these treatments from about 4 to 7 years, and then they might go on to the next line of therapy. So one of the things that we have to understand when we think about the continuous versus time-limited treatments is the fact that how we sequence the drugs might actually impact the ability for us to fund more patients with more drugs. But we're not taking the cost as the primary reason to do that. I think it's important for you to understand that, but it's also important for you to know that it is something that we're also managing as physicians, as well as sort of the resources that are put into this. And this is just to show that if you have high-risk disease, those costs are increased. So in conclusion, I think it's really evident that every person has a unique story and a unique profile, and that one size doesn't fit all. So we are in an era of personalized medicine because we have the options to do that. When we had very limited options, it was really a recipe. Now we have, choose your own adventure, and we can actually do something that benefits you along with your disease. So thank you very much.
Yeah, it's okay. Thanks so much, Dr. Banerji. Again, another wonderful presentation. We have time for perhaps 2 or 3 questions, but then we may move on to the next speaker so we don't keep you too late from lunch. I think in the back corner, I'll turn it over to Dr. Banerji.
I'm not a conspiracy theorist or any of those things, but what you just said just struck me. Is the research going into medication that needs to be taken long term, or is it still research going into medications that are short term, like FCRs, et cetera? I mean, gosh, there are so many of us probably in this room who are on meds that we take every day that we've been taking for years, for reflux, for blood pressure, blah, blah, blah. Is there really a incentive for the drug companies, which we know are making a killing, excuse the pun, to find treatments that are shorter term?
Yeah, so I think a lot of so when these novel agents were introduced, you have to understand the context of CLL. So CLL was being treated with chemotherapy in 6-month intervals. If you got more than 2 years out of it, when you relapsed, you got literally the same thing over again. And so basically, we didn't really have any more options outside of the bone marrow transplant or some very aggressive antibodies that could cause significant infection complications. And patients, unfortunately, would succumb to those that progressive disease. So the era in which the treatments came in and the way they were studied in that continuous manner was because there wasn't a clear signal as to if you could stop. So the philosophy of treatment was that these drugs basically came to rescue patients, and the safest thing to do was keep them on those treatments until that time. Now, what happened over time is we started to shift where those treatments come into play. They started to move earlier and earlier and earlier into lines of therapy, but the philosophy around, when to stop was not changed. And part of the reason for that is, although we have talked about the obinutuzumab creating a deep response, the venetoclax creating a deep response, the challenge is the BTK inhibitors don't. Only 30% of patients will clear their bone marrow space. So there was a concern that if we couldn't get rid of all of the cancer from the bone marrow, then it's better to control it rather than to actually stop the drug. So the combinations that you're seeing now are actually to maximize the depth of response. We can see the blood response, we can see the lymph nodes shrink, but the bone marrow was the hardest thing to treat. So the combinations of like the BTK inhibitors and the BCL2 inhibitors or the venetoclax and the obinutuzumab are actually achieving that depth of response in the bone marrow space. And that's what's actually allowing for the treatment-free remission, because we have the ability to potentially delay the relapses that would have otherwise happened if we stopped the BTK inhibitors when we know we hadn't cleared their marrows effectively.
Is there any other questions? It's okay if there's not. Yeah, maybe just directly to answer that really sort of thoughtful question earlier, most of the research more recently has actually been in time-limited treatment options or figuring out who we can safely stop therapy in. And so it's actually counter to what you might have been kind of speculating. Are we ever going to get short duration therapies because there's an incentive to be on therapies long term? It's actually the exact opposite, which has been happening within the CLL research community and trials. Yeah.
You mentioned beta-2 microglobulin as an indicator. Could you comment on its use as an indicator of tumor load and also the disease progression?
Yeah. So there's a couple of things that we try and use when it comes to simple blood tests that can also be combined into a complex score to predict how well people will do. But the beta-2 microglobulin is something that is shed often from the white blood cells and accumulates in the system. So the greater the burden of the cells, the more these accumulate in the blood. And so there's a normal range that's associated with it. Anything above 1.5 times that normal range, so typically 3.5 is the number that we use, at least for the score. But we can track that level over time as a marker of disease burden. The one caveat to that is because your kidneys need to be functional to clear it, you have to have normal kidney function for us to use it as a marker. But you can tell in patients over time, if you follow them, if their lymph node burden is increasing or their white count is increasing, there will be a slow change over time. If it starts to change more rapidly, let's say in someone who's on treatment where the levels are low and then all of a sudden you see it rise, then you might start get concerned that maybe there's a change in the disease burden that you may not be able to measure in the blood test. So the physical examination, things like that, may be far more important then, because sometimes the blood counts, especially when patients are on therapy, remain in remission longer than their nodal disease. And so that beta-2 might be an important marker. But it's used in the sense because we don't have the molecular testing available in that pre-treatment era as kind of a surrogate for that. It has been combined in what we call the CLL IPI or the CLIPI score with other high-risk features like 17p deletion, IGVH unmutated status, age, and stage to create a composite score that predicted if that score was 4 or more, then patients who had that highest risk category may not have the best outcomes. But we have to take into consideration that a lot of that data was generated when we only used chemotherapy. So I think now there's constant evaluations with the novel treatments as to what are the best predictors of progression. Beta-2 still looks like it's one of them. We did look at patients who were relapsing post-ibrutinib therapy, and we could see that both their LDH and their beta-2 microglobulins were rising, even though it was within the normal range. So it wasn't actually crossing that threshold where it would be flagged by the system as being an abnormal test result, but there was slow indication that it was changing as patients progressed. Thank you.
Thanks so much, Dr. Banerji.